Welcome to AETCM, the emergency medicine channel. Today let us discuss about management of myocardial infarction in emergency room. When we approach a case of chest pain in emergency room, we know that there are a lot of conditions which can mimic myocardial infarction both for the patient and for the physician. So some conditions will mimic just like myocardial infarction. All symptoms, signs, everything will be like myocardial infarction. But when we investigate that case, we will come to know that it's only a benign condition. But the anxiety for the patient is very high because we have to clearly tell that whether it is myocardial infarction or not. So there are a lot of cardiac conditions which can produce myocardial infarction-like features or chest pain. One is ischemic heart disease, that is angina. Whenever patient is having like exertion, they can have chest pain. Most of the time it subsides with rest, whereas myocardial infarction will never come down with rest. Myocardial infarction, severe chest pain radiating to left shoulder, left arm, sweating, palpitation, fear of death. Even if the patient takes rest or sublingual sorbitrate, it will not come down. Myocarditis is a slowly progressive disease, like viral myocarditis. Maybe patient can have viral fever symptoms, then slowly chest pain develops, and this pain will persist. It will not increase or decrease suddenly. Pericarditis, patient can have pain on the pericardium, that means on the left sided chest, and when the patient leans forward, the pain comes down. On auscultation, you can get pericardial rub. Mitral valve collapse, whenever patient is anxious or after exertion, they can have palpitation and chest pain, which does not have quality of myocardial infarction pain, but the patient will have more of anxiety, palpitation, all these things. This is very common in thin, tall individuals. Aortic stenosis will have typical features of chest pain. That is because of reduced blood supply to coronaries, because the stenotic part may obstruct the coronary ostium also. So these patients will have exertional chest pain, aortic dissection, or have severe chest pain and back pain, hypotension, lower limb pulsations, BP all may be low. Aortic aneurysm also can have chest pain. Other non-cardiac conditions in that gastric causes are very, very important. So they have GERD, esophagitis, esophageal spasm. Mallory-Weiss syndrome is after vomiting, patient severe vomiting, retching, patient can have blood in the vomit, a small amount of blood in the vomitus. Anxiety, fear, stress, pulmonary embolism, pulmonary infarct, pleuritis, pneumonia, pneumothorax, malignancy, all can have chest pain. In that pulmonary embolism, very important, that mimics sometimes exactly like myocardial infarction. But most of the massive pulmonary embolism, you can get hypotension, and ECG may be normal in most of the pulmonary embolism. Rarely you see findings of S1, Q3, T3. Musculoskeletal pains are very, very common, especially costochondritis. Whenever the patient moves, the pain increases. That is a major feature of musculoskeletal pain. Then neurological pain, especially herpes zoster. Diabetic patients, severe chest pain, always examine the skin, because herpes zoster is one condition. Patient can have chest pain on the chest pain on the left side or right side, and that will be a burning type of pain. Now, acute myocardial infarction is a condition. It is defined as a clinical or pathological event caused by myocardial ischemia, which there is evidence of myocardial injury or necrosis. That means in myocardial infarction, the blood vessels which supply the myocardium, that is coronary arteries, are completely blocked, whereas in ischemic heart disease, unstable angina, it's partially blocked, and when the patient is exerting, the blood supply to that area will come down. Here the blood supply is completely cut off, and the part will die, that is necrosis of the tissue. There are different types of acute coronary syndrome. It can be unstable angina or myocardial infarction. In myocardial infarction, again ST elevation MI or non-ST elevation MI. The major difference between unstable angina and myocardial infarction is patient's cardiac enzymes, that is a marker of myocardial injury, will be highly elevated in myocardial infarction, not elevated in unstable angina. Whereas in ST elevation MI and non-ST elevation MI, ST elevation means in ECG you can see the evidence of myocardial infarction, ST will be elevated. Whereas in non-ST elevation MI, you don't see ST elevation, but you may see ST depression, T wave inversion, Q waves, all these things, but cardiac enzymes are elevated. Now you can see here the pain typically radiates in this direction, left chest up to shoulder on left side, then chin on the upper part, then it may radiate to the medial part of the left upper limb. You can see how the arteries are blocked. Arteries are blocked by cholesterol, fibrin, platelet, plaque. So this plaque can slowly enlarge and it produces ischemia for a long time. Suddenly it ruptures and produces further accumulation of platelets around it and produces complete block of coronaries and tissue death, tissue necrosis. That is myocardial infarction. Now the symptoms are very, very important. Patient can have prolonged chest pain. It will not be relieved with sublingual sorbitrate or rest. That is very important. Then pain radiates in the direction which we have seen in the previous slide. Patient can have severe sweating, anxiety, fear of death, vomiting, breathlessness, hypotension, collapse, syncope. So many other problems can occur because sometimes a massive MI can produce complete reduction in the ejection fraction because the left ventricle will become stunned. It will not pump blood because the blood supply to that part is completely arrested and that part is not getting oxygen, so the muscles will not contract. So patient can develop hypotension, shock, all these things. Now physical signs of sympathetic activation can be there, signs of vagal activation can be there, signs of impaired myocardial function can be there, signs of tissue damage can be there, signs of complication can be there. So we are not going to these signs at present because whenever patient come with acute chest pain, severe sweating, hypotension, radiation of pain, all typical features point towards myocardial infarction. Afterwards, once the acute syndrome is treated in emergency room, we can look for all these signs. In that, patient can have pallor, sweating, tachycardia, vomiting, bradycardia, hypotension. Then S3 can be there. That is very important. S3 on auscultation indicates that left ventricle is in failure. Then bilateral crepitations, lung crepitations are very, very important because that indicates patient is in pulmonary edema. Then patient can have fever. Then complication signs may be valvular regurgitation, especially mitral valve regurgitation. So that is very common because papillary muscle dysfunction, papillary muscle blood supply is completely cut off, and that papillary muscle can have same problem like what we seen in myocardium. Tissue death, necrosis, sudden rupture of the papillary muscles can produce valve prolapse. So this mitral valve prolapse is very, very common here. Now ECG changes in myocardial infarction, we have already seen that there are two types of myocardial infarction. One is ST elevation MI and non-ST elevation MI. In that ST elevation MI, you can see ST segment at the J point in two contiguous leads. That means you can take groups of leads V1, V2, V3, V4, 2, 3 AVF. In that type of leads, the V1 to V4 or V1 to V6 represents anterior wall or anterolateral wall. 2, 3 AVF represents inferior wall. If two leads have similar changes like elevation of ST more than 0.1 millivolt in these leads other than V3 and V2, you can make a diagnosis of myocardial infarction. Whatever it is, even if there is a mild ST elevation in any of the leads with typical chest pain with elevation in the cardiac enzymes, we have to make a diagnosis of myocardial infarction because initially sometimes ECG may not show any changes, but troponin I, troponin T can be elevated in the initial phase itself. Some patients, due to some reason, you don't see much ECG changes. But troponin I, troponin T elevation and typical chest pain, we should make a diagnosis of myocardial infarction. New onset of left bundle branch block also indicates myocardial infarction. So that is also very important. To diagnose myocardial infarction in left bundle branch block, we have other criteria, but that we are not discussing now. But a new onset of left bundle branch block indicates myocardial infarction. Okay, so that is very, very important. ECG changes may or may not be there, but chest pain with elevated cardiac enzymes will diagnose myocardial infarction. One more important thing is, many patients who are diabetic, they may not have chest pain. They can have myocardial infarction, but they may not have chest pain. This is called as silent myocardial infarction. This is due to autonomic nervous dysfunction in diabetic patients. So you should be very careful. Patients with diabetes can have myocardial infarction without chest pain. In that type of patients, acute breathlessness, acute onset of breathlessness due to pulmonary edema can be considered as a angina equivalence. So angina equivalent means patient does not have angina, but patient is having a coronary artery problem that leads to left ventricular failure and breathlessness. So that also can be taken as into consideration for diagnosing myocardial infarction. So depending on the ECG leads, I am not going to explain all these things in detail. You can see this chart. Depending on the ECG leads, where ST elevation or T-wave inversion, deeply inverted T-waves, all these things, you can make a diagnosis which artery is probably having a block in this type of myocardial infarction. So you can see this chart. Wherever there is a block, like anterior wall MI, septal MI, lateral MI, inferior MI, posterior MI, right ventricular MI, atrial MI, all these things, ECG leads are, some leads are specifically involved in that type of MI. So you can read about these types of changes, but cardiac enzyme has to be elevated. Now ST elevation MI means ST segment is elevated. Here you can see first ECG, ST segment is elevated, at least 2 consecutive leads, at least 1 small box elevation has to be there. But depending on the time, this is a time sensitive change. So depending on the time, you can get various other changes. Initially it may be very tall T waves, then ST elevation can be there, then ST will come down and T wave will form. Sometimes deeply inverted T wave can be there. And non-ST elevation, you may only get ST depression or deeply inverted T waves. Afterwards you get Q wave also. So there also you get cardiac enzyme elevation. And once there is an infarct, that means that tissue death occurs, you will see Q waves. Q wave is a first negative deflection in the QRS complex. If there is a significant Q wave in any of these 2 leads, then you can tell that there is a previous myocardial infarction. Suppose patient had developed myocardial infarction 2 days back, now there is no chest pain, you are taking an ECG, you are seeing significant Q waves in V1, V2, V3, V4, but there is no ST elevation. That indicates the MI had already occurred and that part is having tissue necrosis and death. Significant Q wave means it has to be 25% of the following R wave. So if R wave is 10 small squares, then Q wave has to be more than 2.5 small squares in depth. Then only it will be a significant Q wave. Now you can see here 2 ECGs. First ECG, you can see ST elevation in V1, V2, V3, V4, V5, V6. So it's an extensive anteroseptal myocardial infarction. You can see some reciprocal changes in lead 2 and 3 and AVF. There you can get ST depression. So this is called as reciprocal changes. Whenever there is an ST elevation in the anterior leads, you get ST depression in the inferior leads. This is reciprocal change. So here first ECG is acute myocardial infarction in the anteroseptal area with a reciprocal change seen in ECG in inferior leads. Whereas the other ECG, there is ST elevation in lead 2, lead 3, lead AVF, that is in inferior leads. So this patient is having acute myocardial infarction in the inferior wall, and you are seeing a reciprocal change in V1, V2, V3, that is a reciprocal change. So two ECGs are here. One is anteroseptal extensive anterior wall myocardial infarction, other one is inferior wall myocardial infarction. Now, non-ST segment elevation or NSTEMI means ST segment elevation is not there, but arteries are completely blocked, cardiac enzymes are elevated, but ECG does not show any ST elevation. Instead of ST elevation, you can get ST depression or deeply inverted T wave. Now, myocardial enzymes are the most important diagnostic clue to make a proper diagnosis of acute MI. In that, troponin I, troponin T, and CKMB, we always ask. Troponin I and troponin T are more important than CKMB. CKMB rises in 4 to 8 hours and it returns back to 48 hours. Whereas cardiac enzymes, troponin I positive early as 4 to 6 hours. That slightly in clinical practice you can see they become positive faster than CKMB, but it remains for 7 to 10 days. So there are two important things in acute MI. Anybody is coming with acute chest pain, if there is ECG change, then it is a myocardial infarction, then you can send for cardiac enzymes. Suppose the cardiac enzymes are negative, if you are strongly suspect it is myocardial infarction, then take the patient for any procedure like including thrombolysis or angioplasty, whatever it is. But if the cardiac enzymes are not elevated, serial cardiac enzymes we have to do. Every half an hour you can check the cardiac enzyme, see the serial rise of the cardiac enzyme. That has to be done. And reinfarction, suppose you thrombolyze the patient and patient is in your ICU, and again after 2 days patient is developing chest pain, that can be either in post-infarction angina or a reinfarction, like second time patient is developing myocardial infarction. So in reinfarction, CKMB will be a better choice because initially it will elevate and very fast it will come down, whereas troponin I, troponin T, it elevates fast but it remains there for longer period. So that is not a good investigation for reinfarction. You can see here this chart will tell you how CKMB elevates and goes down, how troponin I elevates and goes down. Now, management is very important in any myocardial infarction. First of all, we have to make sure that it is myocardial infarction or something else. If it is myocardial infarction, we have to always take care of patient's airway, breathing, circulation, because many patients can have breathing difficulty in myocardial infarction because of pulmonary edema. So you need to give oxygen, you need to give non-invasive ventilation, that is BiPAP machine. You have to use to prevent pulmonary edema. BiPAP or CPAP machine you have to use to prevent pulmonary edema. So that has to be started. Then what is most important is if there is no hypoxemia, no need to give oxygen. That produces more problem than like an advantage. It is a disadvantage to the patient myocardium. So don't give oxygen unnecessarily. Then morphine, that is the next important drug, because patients have a lot of anxiety, fear, tachycardia, all these things. We have to relieve patients' anxiety. So you give morphine. You can start with 2 to 5 milligrams, slowly increase the dose. 1 or 2 doses you can give. Along with that, we have to give antiemetic. That is very important. Antiemetic and morphine. That is very important. Morphine has got some side effects, like it can produce bradycardia, it can produce hypotension. So we have to be very careful. If there is already an inferior wall MI with bradycardia, don't try to give morphine. You can go for alternate drugs like fentanyl and all. Morphine should be given only in patients with normal heart rate and normal BP. Otherwise, don't try morphine. It can produce adverse effects there. Now, antiplatelets should be always started. There are two important drugs, aspirin and clopidogrel. Both should be given initially itself. Aspirin 300 mg, clopidogrel 300 mg should be started as soon as possible. Aspirin can be given as a crushed tablet so that it will start absorbing from the mouth itself. and afterwards continue aspirin and clopidogrel in 150 and 75 combination. It has to be continued. Instead of clopidogrel, we can give prasugrel or ticagrelor. There are two important drugs, but nowadays we use ticagrelor. The dose is 180 milligram. That has to be given in patients with acute myocardial infarction. So aspirin, clopidogrel or aspirin, ticagrelor. That is a treatment of choice when the patient come to emergency room in acute conditions. Statin has to be given for all patients who is having myocardial infarction or stroke. You can give 80 milligram of atorvastatin or 40 milligram of rosuvastatin immediately, irrespective of patient's cholesterol status. We have to start statins. Now next drug is beta blocker. You can give metoprolol 5 milligram IV. That is very important because some patients can have unwanted tachycardia in myocardial infarction. So that produces more stress on the myocardium. More heart rate means more oxygen consumption by the myocardium, but the supply is less, blood supply is less. So you have to control the heart rate. You have to give beta blocker to control the heart rate. Only thing is, in the patient, if in the event of failure, you have to be very careful. You cannot use beta blocker in that condition. Bradycardia, hypotension and all, we cannot use beta blocker. Otherwise, we have to give metoprolol if there is no there is no problem like asthma, heart failure, hypertension, bradyarrhythmias. We have to give metoprolol 5 milligram IV. We can give repeated doses up to 15 milligram. Statins we already discussed. Atorvastatin 80 milligram. Atorvastatin has to be given. We have to follow up the LFT afterwards because statin can sometimes produce LFT changes and myositis. So CK and LFT should be checked. Now, if the patient coming to a center where there is PCI facility, that is primary percutaneous coronary intervention or angioplasty, the cardiologist can take the patient for PCI. So that is very important that initial management should not take too much time. So patient coming with chest pain, you diagnose it is probably myocardial infarction. Immediately we have to shift the patient to cath lab because time is heart, time is brain. That we should remember. If you lose time for all investigations, all procedures, then the recannulation will be delayed and the tissue death and tissue necrosis will be very large. Now, thrombolysis can be tried in patients who come to a facility. There is no who come to a hospital. There is no facility for PCI. We can go for thrombolysis. But remember, PCI is better than thrombolysis. But if there is no facility for PCI, we have to definitely take the patient for thrombolysis. We can give streptococcus 1.5 million units in 100 ml saline given as IV infusion for 1 hour. We can even give alteplase, that is TPA. So both the drugs are can be given. Only thing is, patient should not have hypertension or hypotension, and patient should not have active bleeding tendency during the period, or patient should not have recent like large ischemic stroke or hemorrhagic stroke. Like that, there are some indications and contraindications for thrombolysis. Details will be given afterwards when we discuss about thrombolysis. But thrombolysis has to be given if you are not taking the patient for any procedure. Now, anticoagulation. Remember, anticoagulation will not help you to treat myocardial infarction. Anticoagulation is given for, there are two important reasons for anticoagulation, that like we give heparin. One is to prevent the propagation of thrombus. You know that when there is a thrombus in our artery or vein, the platelets, fibrin all go and attach there, and it is the thrombus will enlarge. So that is propagation of thrombus. To prevent that, we have to give aspirin in arterial thrombosis along with heparin, because heparin is fibrin, it prevents fibrin accumulation. Aspirin prevents platelet aggregation. Whereas in venous thrombosis, we need to give only heparin and warfarin. So heparin has to be started. bolus 60 to 70 units per kg, maximum 5000 units, IV followed by infusion of 12 to 15 units per kg per hour. So that has to be started. APTT should be kept in between 50 to 75 seconds. Now follow-up is very important in myocardial infarction because we have to advise the patient to stop smoking, reduction in alcohol intake, regular graded exercise, diet regulation, weight reduction, lipid lowering. All these things are important, and aspirin clopidogrel has to be continued in all patients, or we can go for aspirin with ticagrelor. That is also advisable treatment. So that can be continued in 90 milligram per oral BD. Maintenance dose should be continued. Then 60 milligram per hour BD. Beta blocker, if possibility is there, we have to continue beta blocker because that improves the myocardial performance. But only thing is, if there is a heart block or severe cardiac failure, myocardial infarction induced left ventricular failure, we have to be very careful. In left ventricular failure, we have to start a very low dose and build up the dose slowly. AC inhibitors should be started to reduce the ventricular remodeling. So ventricular remodeling means after myocardial infarction there will be a possibility of death of that myocardial tissue and thinning of the myocardium and bulging of myocardium like a balloon. So to prevent that, we can start AC inhibitors or ARBs. That has to be started. Ramipril 2.5 to 20 milligram daily, lisinopril 5 to 10 milligram per daily can be started. Statins, like we discussed, statin has to be started for all patients who is having myocardial infarction or stroke, and it has to be continued irrespective of their cholesterol status. No need to check their cholesterol. If we can check the cholesterol and understand what is the risk factor for myocardial infarction, but statin has got additional capability of plaque stabilization. It is not only used for to reduce the cholesterol, but also for plaque stabilization. So we have to continue statin. And spironolactone is a drug. It's a diuretic that is used for same purpose like AC inhibitors. That also reduces the ventricular remodeling. And if the patient is not fit for any of these things what we discussed, and it's the infarct area is very large, left ventricular failure is there, valvular replacement is required, or 3 or more area block, then the patient may not be fit for a angioplasty, or he may not improve with angioplasty. Then only coronary artery bypass graft will be done. That means when the artery is blocked, a bypass is created from other artery or other major artery, and the blocked area will be bypassed, so that the distal part of the coronaries will get good supply. So that is sometimes it is taken as a rescue bypass, because if the angioplasty fails, patient does not improve, immediately we have to take the patient for bypass graft. Sometimes after some time elective procedure can be done. So we have discussed about one of the important problem, that is acute myocardial infarction in emergency room. What we should remember is there are a lot of differential diagnoses for chest pain in emergency room that we have to find out, and we should know to read ECG properly. We should be able to diagnose in ECG what is myocardial infarction. We should know how to interpret the cardiac enzymes, and both cardiac enzymes and ECG are very important to make a diagnosis of acute myocardial infarction. Then remember, aspirin, clopidogrel or ticagrelor, statin has to be given from the emergency. Then the patient can be taken for thrombolysis or PCI. That is, all these things are very important. We should not delay any procedure, because there is something called as door to needle time. You have to minimize that, less than 30 minutes or whatever it is. We have to minimize that. That means from door, that the patient is coming to emergency room door, to the needle time. Needle time is not IV line. Needle time means either you thrombolyze or you put the patient for PCI. That time has to be minimized. So unwanted investigation, unwanted procedures all should be avoided. The patient should straight away go for thrombolysis or PCI as soon as possible in a good emergency room. Thank you.